this video, we will discuss some MCQs from the related topics. All MCQs are followed by an explanation. It is recommended that you try to answer the MCQ yourself first before listening to the explanation. Question number 1. Growth hormone release is inhibited by which of the following? Ghrelin, dopamine, serotonin, hypoglycemia, somatostatin. Growth hormone release within the body is very finely managed. There are certain stimulators of growth hormone release and certain inhibitors. This table gives us a few of them. As you can see, the stimulators include growth hormone releasing hormone, ghrelin, which is a hormone, dopamine, hypoglycemia, and exercise. Whereas growth hormone inhibitors include growth hormone itself, somatostatins. Somatostatins are also hormones. They are also called growth hormone inhibiting hormones. Insulin-like growth factors, and glucose and free fatty acids within the blood. In this case, the right answer is somatostatins, as none of the other options given were growth hormone inhibitors. Question number 2. A 4-year-old boy presents to a pediatrician. He is found to be 2 standard deviations smaller in height than his age fellows. His wrist and knee x-rays shows that his bone calcification is delayed. After ruling out other causes, a diagnosis of growth hormone deficiency was made. Which of the following is the appropriate drug for him? Octreotide, pegvisomant, cabergoline, somatropin, tesamorelin. So this child is deficient in growth hormone. As a result, he is having stunted growth and delayed bone age. We need a drug for him that will fulfill his growth hormone requirements and allow him to grow properly. Out of these 5 options, the right answer is D. Somatropin. Somatropin is a recombinant form of human growth hormone and is the right option for those who are suffering from innate deficiency of growth hormone. Looking at the rest of the choices, octreotide is a somatostatin analog. Somatostatins are growth hormone inhibitors, so somatostatin analog is not the right option. Pegvisomant is growth hormone receptor antagonist. Cabergoline is dopamine receptor analog, and tesamorelin is a synthetic form of growth hormone releasing hormone. However, it is not approved for use in people with growth hormone deficiency. So the right answer here is somatropin. Question number 3. A 5-year-old boy was 2.5 standard deviations below mean height for his age and also has delayed bone age. He was diagnosed as having mutations in growth hormone receptor and post-receptor signaling, which made him resistant to growth hormone. Which is the appropriate drug for him? Recombinant human growth hormone, pegvisomant, mecosermin, ghrelin, somatostatin. Now this question is very similar to the previous one. However, unlike the previous one, there is no growth hormone deficiency in this case. Instead, the growth hormone receptor is mutated and there is a problem in post-receptor signaling. As a result, growth hormone cannot exert its effect. We need a drug that would overcome this blockage at the level of receptor. If you look at the options, you will see that A is recombinant human growth hormone. We don't need this as there is sufficient growth hormone in the body. B is pegvisomant. It is a growth hormone receptor antagonist. Again, not needed. C is mecosermin, and this is the right answer, and we will see in a minute how this is so. D is ghrelin. Ghrelin is, as we discussed in question number 1, is a hormone that stimulates the release of growth hormone. But there is already sufficient growth hormone in the body and we don't need to give ghrelin. Somatostatin is growth hormone inhibitor. Again, this is not the right option. So mecosermin is the right answer, and why? Now, if you look here, you will see that growth hormone exerts its effects by increasing the level of IGF in the body. IGF is insulin-like growth factors. So the effects of growth hormone are mediated by this hormone. Mecosermin is recombinant form of IGF. So in a patient where growth hormone receptor is mutated, or there is post-receptor signaling pathway deficiency, or there is antibodies against growth hormone, or the patient is primarily deficient in IGF, mecosermin is the right option as it bypasses all these problems and leads to an increase in IGF levels, which can then mediate all the effects of growth hormone. Question number 4. Growth hormone therapy is also approved for children who have growth failure despite normal growth hormone production. In which of the following congenital disease is growth hormone usually given? Klinefelter syndrome, Down syndrome, cleft palate, Noonan syndrome, cerebral palsy. Now, this is again a growth hormone related question. As we saw previously, there can be deficiency of growth hormone, or there can be a deficiency or problem with the signaling pathway of growth hormone, or the patient can have sufficient amount of growth hormone and no problem with receptor, yet they fail to achieve normal growth. This is especially evident in children with congenital diseases. In certain congenital diseases, growth hormone therapy is thus indicated to allow those children adequate growth. Out of these 5 options, the right answer over here is Noonan syndrome. Some congenital disorders lead to stunted growth, such as Turner syndrome, Prader-Willi syndrome, Noonan syndrome, in children with chronic renal insufficiency, and in children who have idiopathic short stature and they are short for gestational age with a failure to catch up to their peers by the age of 2 years. In all these conditions, the children have stunted growth and they benefit from a growth hormone therapy, and thus growth hormone therapy is indicated for these conditions. Question number 5. Which of the following is not an indication for the use of growth hormone therapy? Patients with short bowel syndrome, wasting in patients with HIV, pituitary adenoma, idiopathic short stature, Turner syndrome. Now, the previous question was about in which case the growth hormone therapy is an indication. This question is opposite, in this question you have to tell which of the following conditions is not an indication for growth hormone therapy. If you look here, the answer is pituitary adenoma. A pituitary adenoma will already be producing excessive growth hormone. So we don't need to give an exogenous growth hormone as well. In all the other cases listed, growth hormone therapy is approved and indicated. Question number 6. Pegvisomant is approved for treatment of acromegaly. What is its mechanism of action? A. Somatostatin analog. B. Growth hormone receptor agonist. C. Growth hormone receptor antagonist. D. Dopamine receptor agonist. E. IGF-1 blocker. Now, acromegaly is a condition that results from excessive release of growth hormone within the body. We need a drug that would block the effects of excessive growth hormone. So, which of the following is so pegvisomant is an approved treatment. We have to tell you which is its mechanism of action. Pegvisomant is a growth hormone receptor antagonist. It binds with the growth hormone receptor, thus it blocks the growth hormone from binding to the receptor and mediating its effects. Question number 7. A pre-diabetic patient with pituitary adenoma undergoes endoscopic transsphenoidal surgery. High levels of growth hormone still persist post-surgery. The patient is started on somatostatin analogs. What should she be regularly tested for? A. Liver function and glucose tolerance. B. Thyroid function. C. Bone density. D. Glucose tolerance and thyroid functions. E. Glucose tolerance only. Now, this patient is pre-diabetic. She had a pituitary adenoma for which she underwent surgery. But after surgery, there is still high levels of growth hormone. So the patient is started on somatostatin analogs. Now, what should she be regularly tested for out of all these? The answer is D, that is glucose tolerance and thyroid function test. Why? Now, if you look here, you will see that somatostatin analogs, which include octreotide, lanreotide, and pasireotide, reduces release of growth hormone and TSH from pituitary. Now, as it reduces the release of thyroid stimulating hormone from the pituitary, it can lead to hypothyroidism eventually. At the same time, somatostatin analogues also decrease insulin secretions from the pancreatic islet cells. As the insulin secretion decreases, there is a chance that glucose tolerance will worsen. But at the same time, as the growth hormone levels in the body will fall, insulin resistance will lower. The cells will become more receptive to insulin as excessive levels of growth hormone leads to insulin resistance. So both of these effects will play side by side and the patient can have worsening or improvement of glucose tolerance. We have a patient that was pre-diabetic, we need to regularly monitor her for glucose tolerance and we need to monitor her thyroid function to see if she is developing hypothyroidism. Question number 8. Which of the following drugs will increase levels of prolactin in the body? Bromocriptine, cabergoline, atosiban, proton pump inhibitors, antipsychotics. Prolactin is another hormone that is released by the pituitary gland. There is a list of 5 different drugs. You have to tell the use of which drug can lead to increased levels of prolactin in the body. The answer here is E, antipsychotics. Now, how is the answer here? So, if you look at this diagram, you will see that dopamine is the main inhibitor of prolactin release. Any drug that inhibits dopamine release or blocks the effect of dopamine will lead to an increased levels of prolactin within the body. Now, the drugs that lead to decreased dopamines include antipsychotics, opiates, estrogen, metoclopramide. So, if any patient is taking these drugs, that patient will likely have an increase in the prolactin levels in their body. So, the answer here was E, antipsychotics. Question number 9. A 35 years old female presents to OPD with complaints of difficulty in conceiving and amenorrhea since last 1 year. She also reveals that since last few months she is having worsening headaches and blurry vision. MRI reveals a small pituitary mass. Serum prolactin levels are 320 nanograms per deciliter. Which of the following is a treatment of choice for her? A. Transsphenoidal surgery. Surgery followed by dopamine antagonist, octreotide, cabergoline, oral contraceptive pills. So this question is again related to prolactin. The history and symptoms tell us that she is having high levels of prolactin in the body. High levels of prolactin in the body is making it difficult for her to conceive and causing her amenorrhea. The pituitary adenoma, the pituitary adenoma that is producing the excess of prolactin is causing her headaches and blurry vision. We need a treatment such that will decrease the levels of prolactin in the body and also decrease the pituitary adenoma mass so that she is relieved of headaches and blurry vision. Now the right option here is not surgery, not radiation, but drug. That drug is dopamine agonists. Dopamine agonists are the first line treatment in patients suffering from hyperprolactinemia or prolactinoma. Dopamine agonists decrease the size of prolactinoma and they decrease prolactin secretion. Dopamine agonists include cabergoline, that was the option number D. Question number 10. A 7-year-old female child starts developing secondary sexual characteristics and is identified as having a central precocious puberty. That is, precocious puberty secondary to gonadotropin releasing hormone causing excess secretion of gonadotropins. What is the treatment of choice for her to allow her to achieve optimal adult height and pubertal development congruent with her age fellows? A. Oral contraceptive pills. B. Continuous administration of gonadotropin releasing agonists. Pulsatile administration of gonadotropin releasing hormone agonists. Gonadotropin releasing hormone antagonists, or menotropins. Now, this question is about a female child who is only 7 years old but is developing secondary sexual characteristics or is she is undergoing puberty. Now, this puberty is a result of excessive release of gonadotropin releasing hormones. Those excessive release of gonadotropin releasing hormones is causing her pituitary to release gonadotropins. The gonadotropins includes FSH and LH, which is leading to puberty. Now, in the body, gonadotropin releasing hormone is released in a pulsatile manner. It is released intermittently. Intermittent release of gonadotropin releasing hormone stimulates the pituitary to release FSH and LH. If gonadotropin releasing hormone is produced or given in a continuous fashion, in a continuous chronic way, they lead to suppression of gonadotropin release from the pituitary. So the right answer here is gonadotropin releasing hormone analogs or agonists. They are given to this child. What they will do, they will not only suppress the release of gonadotropins, they will also cause desensitization and downregulation of gonadotropin releasing hormone receptor on pituitary gonadotrophs. As a result, the pituitary will stop producing FSH and LH and allow the child to grow in congruence with her age fellows. Question number 11. Oxytocin is used for induction of labor and to augment uterine contractions after delivery to prevent postpartum hemorrhage. Which of the following toxic reactions can occur from high doses of oxytocin? A. Anaphylaxis. B. Malignant hypothermia. C. Hypertension. D. Fluid retention. E. Bradycardia. Now, oxytocin is another hormone that is released from posterior pituitary. Oxytocin is also given exogenously to induce labor and augment uterine contractions. However, high doses of oxytocin can lead to toxic reactions. Which of the following toxic reaction is the right answer? The right answer is D, which is fluid retention. Oxytocin activates V3 receptors in the body. V3 receptors have antidiuretic effects. As a result of their antidiuretic effect, they retain fluid. Fluid retention leads to hyponatremia, which leads to heart failure or seizures and can eventually result in death. At the same time, bolus doses of oxytocin can cause vasodilations. Vasodilation will lead to hypotension, which will again lead to fluid retention by the kidneys, and also it will lead to reflex tachycardia. So the right answer here is fluid retention, and it is important to remember that oxytocin should be given in a dilute solution at a controlled rate. Question number 12. What is the mechanism of action of desmopressin? It is a V1 receptor agonist, V2 receptor agonist, stimulates release of ADH from posterior pituitary, V2 receptor antagonist, V1 receptor antagonist. Now, desmopressin is a drug that is the treatment of choice for patients suffering from diabetes insipidus as a result of decreased release of antidiuretic hormone from the pituitary gland. Desmopressin is the synthetic analog of vasopressin, that is the natural hormone, also known as antidiuretic hormone. Mechanism of action of desmopressin is that it is a V2 receptor agonist. It is a V2 receptor agonist. V2 receptors are found on renal tubular cells and reduce the diuresis through increased water permeability and water resorption in the collecting tubules. Question number 13. Now we start with thyroid gland. Levothyroxine is the drug of choice for hypothyroidism. It consists of T4 only, T3 only, 75% T4 and 25% T3, desiccated thyroid extract of animal origin, T4 with iodine supplement. So levothyroxine is given in patients who have hypothyroidism, meaning that their thyroid gland is producing decreased amount of thyroid hormone. Natural thyroid hormone consists of that is released from our thyroid gland consists mainly of T4. T4 is converted within the body to T3. T3 is the active form that exerts the effects. So if we are giving exogenous thyroid hormone, that is in the formulation of levothyroxine, is it T4, T3, a mixture of both, or a desiccated extract from an animal origin? The answer is levothyroxine consists only of T4. We never give desiccated thyroid because firstly it is antigenic and secondly it will have a variable amount of hormone concentration. T3 is also not given because it is less effective in feedback regulation of thyroid stimulating hormone from the pituitary gland. It has also higher propensity of causing cardiotoxicity. However, in certain conditions, we do give T3 as well, such as when we need rapid action in patients suffering from myxedema, coma. Question number 14. Which of the following statements is correct? Lesser dose of levothyroxine is required in pregnancy. Higher dose of levothyroxine is required in pregnancy. Dose of levothyroxine required in pregnancy is same as that required before pregnancy. Levothyroxine should be stopped in pregnancy. Only leothyroxine should be given in pregnancy. So this is a question that relates to administration of levothyroxine in a pregnant female who suffers from hypothyroidism. How should her drug be managed and her hypothyroidism be managed during pregnancy? Should we give her lesser dose of levothyroxine or a greater dose of levothyroxine, or we make no changes in the doses of levothyroxine, or whether it should be stopped or not? The right answer here is in pregnancy, higher doses of levothyroxine are required. Why is it so? Estrogen induces an increase in serum thyroid binding globulin, which decreases the free T4 in blood. In pregnancy, there is higher level of estrogen in the blood. Estrogen causes an increase in the serum thyroid binding globulin. As a result, the free T4 decreases. Free T4 is the active form. At the same time, some of the T4 binds to receptors on placenta and also moves inside the placenta, resulting in further decrease in maternal free T4 levels. It is very important to adjust the dose of levothyroxine in pregnancy because even mild hypothyroidism in mother increases the risk of miscarriage and impaired motor and neuropsychological development of fetus. So doses of levothyroxine should be increased in pregnancy. Question number 15. Which of the following is a drug of choice in the management of thyroid storm? A. Methimazole, B. Propyl thiouracil, C. Radioactive iodine, D. Potassium perchlorate, E. Carbimazole. So thyroid storm is a medical emergency in which the thyroid gland suddenly produces a large amount of thyroid hormone and releases into the blood. Which drug out of all the 5 should be given in the management of thyroid storm? The answer is B. Propyl thiouracil. Now, propyl thiouracil blocks hormone synthesis within the gland. At the same time, it inhibits peripheral deiodination of T4 to its active form, that is T3. The other options, methimazole and carbimazole, they do not prevent deiodination of T4 into T3. Radioactive iodine and potassium perchlorate have no immediate effect. At the same time, they do not prevent the peripheral conversion of T4 to T3. Therefore, propyl thiouracil is the most appropriate choice and drug for the management of thyroid storm. At the same time, supportive measures are also needed that include IV fluids, antipyretics, cooling blankets, beta blockers, and sedations. Question number 16. Propyl thiouracil and methimazole are classified in which FDA pregnancy category? A, B, C, D, X. FDA has classified all drugs into the 5 categories according to how safe they are in pregnancy. You have to tell which category propylthiouracil and methimazole belongs to? The answer is D. Category D includes drugs for which there is a positive risk of positive human fetal risk, but the benefit to mother in pregnancy outweighs the risk. So these are category D drugs as there is a significant risk of fetal hypothyroidism, but the benefit of giving these drugs to mother far outweighs the risks. At the same time, it is important to remember that propylthiouracil is preferred in the first trimester because it is strongly protein bound and less readily crosses the placenta. In the second and third trimester, propylthiouracil is discontinued and methimazole is preferred because propylthiouracil is related to liver failure in pregnancy. Question number 17. In management of thyrotoxicosis, along with antithyroid drugs, beta blockers are also started. What is the objective of using beta blockers? They block thyroid hormone receptors in peripheral cells, only blocks conversion of T4 to T3 in periphery, inhibits the release of T4 from thyroid gland, inhibits the organification of iodine in the thyroid gland, prevents life-threatening cardiovascular manifestations of hyperthyroidism. Thyrotoxicosis is when there is an excess of thyroid hormone in the body leading to adverse symptoms. Now, most life-threatening symptoms of thyrotoxicosis includes those that result as those that are because of sympathetic overstimulation. They include tachycardia, increased rate and force of contractions, tremors, anxiety. Beta blockers are used in the symptomatic management of thyroid hormone excess because of two reasons. Firstly, it blocks the conversion of T4 to T3, that is the active form. At the same time, it blocks the effects that are due to sympathetic overactivity, such as tachycardia, increased rate and force of contraction, tremors, anxiety, palpitations, arrhythmias. These are complications that can be life-threatening. So, beta blockers can be life-saving in management of thyroid hormone excess. Question number 18. A 40 years old man is taking amiodarone for atrial fibrillation. Long-term use of this drug puts him at a risk of developing symptoms of which endocrine disorder? A. Thyroid dysfunction, B. Cushing's disease, C. Diabetes mellitus, D. Addison's disease, E. Diabetes insipidus. Now, amiodarone is an iodine-rich drug. Prolonged use of amiodarone leads to high concentration of iodine in the body. Now, that can have two types of effects. High levels of iodine in the body inhibits organification of iodide in the thyroid gland. It inhibits hormone release through inhibition of thyroglobulin protease, and it inhibits deiodinase that converts T4 to T3 in the periphery. So these effects of excessive iodine can lead to hypothyroidism. At the same time, high levels of iodine may lead to gland overfunction in those people who have lower dietary intakes and were deficient in iodine initially. So depending on different people, amiodarone can lead to hypothyroidism or hyperthyroidism. So the patient must be checked for thyroid dysfunction. Question number 19. Propylthiouracil is used in the treatment of hyperthyroidism. What is the mechanism of action of propylthiouracil? A. Blocks uptake of iodine by thyroid. B. Prevents conversion of T4 to T3. C. Inhibits proteolysis of thyroglobulin by blocking the activity of thiol endopeptidases. D. Prevents the oxidation of iodine to its active form by inhibiting the thyroidal peroxidases. E. Increases hepatic metabolism of circulating enzymes. Now, propylthiouracil is a very common drug used in the treatment of hyperthyroidism. You have to tell its mechanism of action. The answer is D. Propylthiouracil mainly inhibits thyroid peroxidases and then prevents the oxidation of inorganic iodide to iodine. It also inhibits coupling of diiodotyrosine and monoiodotyrosine to form T3 and T4. To some extent, it also inhibits deiodination of T4 to T3 in the periphery, but its main action is inhibition of thyroid peroxidase. Question number 20. A 40 years old man with Graves' disease is prescribed propylthiouracil. What is the most serious side effect of propylthiouracil that requires regular monitoring? Renal failure, liver failure, agranulocytosis, Stevens-Johnson syndrome, arrhythmias. The most serious side effect of propylthiouracil that requires regular monitoring is agranulocytosis. Now, agranulocytosis can develop suddenly. Therefore, at the time the medicine is prescribed, patients are advised to stop taking medicine and report to doctor immediately if they develop sore throat or fever. Question number 21. An emotionally unstable teenager who suffers from hypothyroidism takes a massive dose of her prescription drugs. She is taken to ER. Which of the following drugs should be promptly administered to control the life-threatening effects of this drug overdose? A. Prednisolone, B. Levothyroxine, C. Propylthiouracil, D. Propranolol, E. Radioactive iodine. Now, the patient suffers from hypothyroidism and her prescription drug will most likely include levothyroxine. She has taken an excessive dosage of levothyroxine, which will lead to high amounts of T4 within her blood. High amounts of T4 in her blood will resemble a patient that suffers from thyrotoxicosis or thyroid storm. So, this patient will present with the same manifestation as a patient of thyroid storm. So the drug we need to give her to manage the life-threatening side effects of this drug will include D. Propranolol. Looking at the other options, prednisolone has no role. Levothyroxine, well, she is already overdosed on levothyroxine. We don't need to give an extra levothyroxine. C. Propylthiouracil. It will serve to decrease the amount of thyroid hormone released from the thyroid gland, but would do nothing about the excessive T4 that is already in her blood. And radioactive iodine will also have no immediate effect. So the answer, propranolol, is the answer because propranolol has two effects. Propranolol will inhibit the conversion of T4 to T3, that is the active form, in the blood. At the same time, propranolol will provide symptomatic relief and prevent fatal side effects such as arrhythmias, tachycardia, palpitations, anxiety. Therefore, propranolol is the right answer. Question number 22. Which of the following drugs used for hypothyroidism is absolutely contraindicated in pregnancy? A. Methimazole, B. Propylthiouracil, C. Carbimazole, D. Iodide, E. Radioactive iodine. Answer is radioactive iodine. Why? Because radioactive iodine is trapped by the thyroid gland. Within the thyroid follicle, the radioactive iodine gives off beta particles that destroy the parenchymal cells of thyroid. As a result, the hyperthyroidism is cured permanently. It is contraindicated in pregnancy because after the first trimester, fetal thyroid will also concentrate radioactive iodine and get permanently damaged. Moreover, even in the first trimester, radiation from radioactive iodine may adversely affect developing fetal tissues. So, radioactive iodine is absolutely contraindicated in pregnancy and should not be used. Question number 23. Patient presented to OPD with complaint of worsened glucose control and sustained high blood pressure. She had rounded swollen face and truncal obesity. She was diagnosed as having hypercortisolism. Which drug is used to differentiate whether it is secondary to pituitary ACTH or not? A. Dexamethasone, B. Hydrocortisone, C. Prednisolone, D. Fludrocortisone, E. Methylprednisolone. So with this question, we finish the thyroid gland and start with adrenal gland and hypothalamic pituitary and adrenal axis. This patient in this question suffers from hypercortisolism. Now, hypercortisolism can be because the patient has an adrenal adenoma, that is secreting excess amount of cortisol, or it can be due secondary to excessive production of ACTH by the pituitary gland. To find out what is the case, we use one of these following drugs. Which is that drug? The answer is A. Dexamethasone. This is called dexamethasone suppression test. In dexamethasone suppression test, 1 milligram of dexamethasone is given at 11 pm at night. In normal individuals, ACTH release from pituitary is suppressed and the plasma cortisol concentration is less than 3 micrograms per deciliter in the morning. However, in a patient with Cushing syndrome in which ACTH is not suppressed, plasma cortisol concentration is greater than 5 micrograms per deciliter. So this test helps us determine whether hypercortisolism was secondary to ACTH production or independent of it. Out of the other drugs listed, dexamethasone is used because it is the more potent glucocorticoid and only a small dosage can be used for suppression. Question number 24. A 59 years old male has been diagnosed as having Cushing syndrome secondary to ACTH producing pituitary adenoma. The patient is not fit for undergoing surgery due to other comorbidities. Which drug should be used to treat his condition? A. Hydrocortisone, B. Fludrocortisone, C. Paclitaxel, D. Corticotropin, E. Ketoconazole. So this patient is having Cushing syndrome and that is because he has a pituitary adenoma that is producing excess ACTH. The patient is not fit for surgery and therefore will have to be managed medically. Which drug will be used? The answer is C. Paclitaxel. Paclitaxel is a somatostatin analog. It inhibits ACTH secretion from pituitary gland. It is the drug of choice for ACTH producing pituitary tumors in patients that are not fit for surgery or who have recurrent disease after the surgery. Question number 25. What causes iatrogenic Cushing syndrome? A. Suddenly stopping steroid therapy. B. Cushing's-like symptoms as a result of chronic stress. C. Symptoms developing as a result of long-standing steroid therapy. D. Cushing's disease due to adrenal tumors. Cushing syndrome in fetuses exposed to high levels of maternal cortisol. So Cushing syndrome results when there is excessive production of ACTH, which leads to excessive cortisol, and the symptoms that develop is what we call Cushing syndrome. What is iatrogenic Cushing syndrome? Iatrogenic Cushing syndrome results when a patient is given exogenous corticosteroid for longer than 2 weeks. The patient start developing symptoms that resemble those of Cushing syndrome, such as puffiness of face, redistribution of fat from extremities to trunk, growth of fine hair over face and thighs and trunk, and thinning of skin and development of stria. This Cushing syndrome that is caused by drugs is called iatrogenic Cushing syndrome. Question number 26. A patient is diagnosed as having Cushing's disease as a result of large inoperable adrenal carcinoma. Which drug should be used regularly to alleviate the symptoms resulting from the excess of cortisol? A. Spironolactone, B. Ketoconazole, C. Fludrocortisone, D. Mitotin, E. Corticotropin. Now this question is slightly similar to the one we have already discussed. In that question, the patient suffered from a pituitary adenoma, which was inoperable. As a result of pituitary adenoma, the patient was producing excessive amount of cortisol, and we gave that patient paclitaxel. In this case, however, there is an inoperable adrenal carcinoma. So we need to give a drug that would overcome the excessive cortisol produced by this adrenal carcinoma. The drug of choice is option number D, mitotane. Mitotane selectively destroys adrenocortical cells. It also lowers the adrenocorticosteroids and adrenocorticosteroids metabolites in the blood. This drug is indicated for palliation of inoperable adrenocortical carcinoma. So remember the difference between the two scenarios: if there is a adenoma in the pituitary gland, or if there is a adenocarcinoma, and both have different management. Question number 27. A 37 years old female patient presents an OPD with consistent high blood pressure that is refractory to treatment. She also complains of fatigue, muscle cramps, headaches, and palpitations. Her routine test reveals hypokalemia and mild metabolic alkalosis. Further tests reveal high serum aldosterone, which is the appropriate drug for her management. A. Fludrocortisone, B. Hydrocortisone, C. Ketoconazole, D. Mifepristone, E. Spironolactone. So this patient is having aldosteronism. There is high level of aldosterone in her serum, which is causing her hypokalemia and mild metabolic alkalosis, and this is also leading to her high blood pressure that is refractory to treatment. So we need a drug that would counter the effects of high serum aldosterone, and the answer is E. Spironolactone. Spironolactone is the treatment of choice for aldosteronism. Aldosteronism can be due to adrenal adenoma or hypertrophy of the adrenal gland. Spironolactone prevents potassium wasting and helps manage hypertension. Question number 28. Which of the following drugs is used to promote fetal lung maturation in premature labor? A. Dexamethasone, B. Prednisolone, C. Mifepristone, D. Prostaglandins, E. Progesterone. So an infant that is born before 34 weeks is premature and does not have proper lung maturation as a result of low levels of surfactant within the lungs. This leads to problems in breathing after birth. So a mother that is likely to have a premature labor is given one of the following drugs to stimulate the fetal lung maturation. You have to tell which is the drug of choice. The drug of choice is A. Dexamethasone. Antenatal glucocorticoids reduce the incidence of respiratory distress syndrome in infants delivered prematurely. We use very potent glucocorticoids. They include dexamethasone or betamethasone. So only as dexamethasone was mentioned in the options, it was the right option. Question number 29. Prednisolone can have all of the following side effects except weight gain, lowered resistance to infections, peptic ulceration, osteoporosis, hypoglycemia. Now, prednisolone is a corticosteroid and can have various side effects. But which of the following is not its side effect? The answer is E. Hypoglycemia. All corticosteroids actually cause hyperglycemia and not hypoglycemia. Some of the other side effects of glucocorticoid therapy include fluid and electrolyte abnormalities, hypertension, hyperglycemia, increased susceptibility to infections, peptic ulcers, osteoporosis, myopathy, cataracts, growth arrest in children, fat redistribution, and behavioral disturbances. Question number 30. A patient with primary adrenal insufficiency requires an exogenous mineralocorticoid. What is the drug of choice? A. Cortisone acetate, B. Fludrocortisone, C. Prednisolone, D. Dexamethasone, E. Mifepristone. Now, adrenal gland produces glucocorticoids and mineralocorticoids. Mineralocorticoids maintains the right levels of sodium and potassium within the blood. A person with primary adrenal insufficiency in which the person is not producing enough mineralocorticoid would require an exogenous mineralocorticoid. Now, you have to tell me which is the drug of choice. If you will look at this table that mentions the relative potencies of various corticosteroids, you will see that different corticosteroids have different glucocorticoid or anti-inflammatory potency and different mineralocorticoid or sodium retaining potencies. They are compared, all these potencies are compared with hydrocortisone, which has the potency of 1 in both glucocorticoid and mineralocorticoid. As you can see from this table, fludrocortisone has the highest amount of sodium retaining or mineralocorticoid property. At the same time, it has very less glucocorticoid potency. So if we need an exogenous corticosteroid only for its mineralocorticoid activity, the answer should be fludrocortisone. So fludrocortisone is the drug of choice in any patient who is suffering from mineralocorticoid deficiency. You can also see from this table that dexamethasone and betamethasone has very high glucocorticoid potency and almost zero mineralocorticoid potency. So these are very potent glucocorticoids which we use in fetal lung maturation in a woman which is threatened to undergo premature labor. Thank you. I hope you learned something from these MCQ discussions.